Thank you so much for joining the API conference call. We're really honored to have extreme noted speakers. Today's topic is oral corticosteroids or corticosteroids in COVID-19. And my name is Lokesh Idara. I'm an allergist practicing for 29 years in Battle Creek, Michigan. We, as an allergy physicians, we treat asthma from age 1 to 90 to 100 years with asthma flare-up with viral infections with short course of steroids. With this, so I'll first introduce Dr. Another allergist colleague, Dr. Anne Suresh. He will be talking about outpatient management of his experience. Then we'll have Dr. Meduri. He is world famous in corticosteroids and ARDS research. Then Dr. Corey, and followed by Dr. Ramesh will be speaking. So I will introduce Dr. Anne Suresh. He's assistant professor of medicine and allergy immunology in Michigan State Medical Society at Flint, Michigan. He actually joined allergy because he's more interested in immunology, and he trained at with Dr. Middleton, who wrote the book on allergy immunology. He himself treated his parents. He lost his father last 2 days. He spent in the ICU with him. He has personal experience with COVID patients, starting as early as third day of COVID patients with oral steroids. Dr. Suresh, can you start, sir?
Thank you, Idara, and thank you everyone for inviting me to speak about steroids in the outpatient. My interest was steroid, as I mentioned that my close person who passed away. Steroid, then I looked into the most of why these people are not surviving, especially once they go into the hospital. So that's all my interest. And I would like to briefly go through. I want to share my screen for now for the next 5-6 minutes. Okay. So I'll start with I have a few patients after what happened to my family, and that initially when I saw one of my patients who is an 84-year-old female, and she was diagnosed of COVID-19 in the emergency room and sent home a week prior. And then after a week, her husband called me that he is a patient with asthma, hypertension, type 2 diabetes mellitus, which he has almost all the comorbid conditions that we usually see in patients that are dying in the ICU. So when he called me, by the time I was already looking into the pathophysiology, why these patients are passing away. And then when I look into the labs, everything about my family member, I found that there is an interesting feature. Initially was there is a lymphocytopenia and monocytopenia. And then it started going up within the next 2-3 days after he really extremely got sick, and that caused his demise, I think. And then we look into that, the whole thing. I felt that this is probably just an inflammatory condition that is causing this seriousness. Once the patient develops this inflammatory condition, it's very difficult to stop it. So with that sense, I started, why can't we treat these patients with steroid before even if they go into the hospital? So he is the patient that I started first, the 84-year-old, and he was fever about 101 to 102 degrees by end of the first day. It was dyspneic. Because his wife was there before, I gave a pulse oximeter to monitor at home. So his pulse ox dropped from 90 to 91%. Even at the rest, it is not going more than 92% to 93%. And he has a severe body pains later on, dry cough, and anosmia. I sent him to get the PCR test, but that is in the evening he called me. So I started him already with oral steroids and then sent him to the PCR next day, which was positive. And his chest X-ray was bilateral patchy infiltrates, and CBC with differential was not that significant, but he had a monocytopenia and lymphocytopenia. If you see, lymphocytes were 350 per ml. His liver enzymes were elevated, and his ferritin was moderately elevated along with the D-dimer. So started treating with the steroids and gave him the paracetamol for fever every 8 hours for the first 24 to 48 hours, and asked him to drink generous fluids. Started on famotidine because of the steroid-induced gastritis to prevent. Measuring his oxygen every 2 hours that night, because it was very nerve-wracking that night for me, because I was not sure whether the steroids are going to help him or he's going to crash in the middle of the night. So he was checking his pulse oximeter every 2 hours, told him to call me if it is less than 90%. If it goes to 89, 88, I asked him to contact me right away. And monitoring his vital signs every 4 hours. Then I also asked him to walk around because of the news that we are hearing about the hypercoagulability and the clots occurring. So I want to make sure that his mobility, to prevent any DVT. And asked him to go to emergency room if his pulse ox was dropped to less than 90%. And within 24 hours, I think next day by noon time, his dyspnea got improved significantly, and his oxygenation got improved by 96%, about 96%. Within 24 hours, it was normal. Fever came back to normal within 1.5 days. His tachypnea and tachycardia was now returned back to the normal. Cough took about 4 to 5 days to resolve, and his chest X-ray completely resolved after 2 to 3 weeks. And in about 3 days, his white count came back to normal level, and his lymphocytes started slowly coming back to the normal, including the monocytes. His liver enzymes became normal, but the ferritin was still higher than normal, but it's between 500 to 600 nanograms per ml. D-dimer was 1.25 microgram, normal being less than 0.5 microgram per ml. His D-dimers were also became normal after 2 weeks of treatment. And he was not placed on any subcu heparin or any other anticoagulation at this time. And what is happening, and then I look into that with the literature, seeing that from the allergist point of view or from immunologist point of view, the disease spectrum of COVID is almost 60 to 70% of the people are asymptomatic or mildly symptomatic. They recover, they don't go to the hospital, they don't seek any advice. And about 10 to 15% of the people, they have severe symptoms, but they're admitted in the hospital while observation or the hypoxemia not that much, around 93, 94. Usually they recover with supportive treatment. And the remaining population, that's a 10% of the population that is really going to the cytokine storm, which is, everybody that knows about the COVID understand about the cytokine storm. They go into the ARDS and start having multi-organ involvement. These are the patients are really at high risk of high mortality. And these are the patients that we call either ARDS or actually the name that was coined because of the inflammation during this SARS-2 or the COVID, the previous coronavirus infection is a secondary hemophagocytic lymphohistiocytosis. As the name says, it is all the hepatic system, especially the immune cells. They were started very highly increasing. Once they go high, it's almost like no return. I know I have to thank many of our colleagues who are working in ICU and intensive care hospitalists and ID specialists, all these working about controlling this uh, SHLH. They have done tremendous job by giving the support and also then I look into the various cytokines. This is, you can see many cytokines that are involved in this system. You can see all these chemokines, cytokines, adhesion molecules are helping the chemotaxis of the factors. And you can see all these adhesion molecules interacting between cell to cell, endothelial cell to cell. These are all leukotrienes, lipid mediators. So all these things involve causing the hyperinflammation with cytokines, proteolytic enzymes. And it causes all these factors resulting in coagulopathies, multi-organ failure, Kawasaki-like syndrome, which we know in the children recently. And all these symptoms, they're the only thing that we can control now. If we are using antibodies specifically to cause one or two cytokines, it's not going to be responsible. So when you look into the literature, you can see this, especially Dr. Meduri, who is going to be talking later, gives you a lot of research done on the steroid effect and controlling the inflammation, this hyperinflammation state to prevent. So we thought it is better to treat them early. As you know, the steroids will stop the synthesis of inflammatory cytokines, also helps to advance anti-inflammatory cytokines. And it controls the inflammation in almost all the organs. And we see all these individual antiviral medications are okay at stopping the viruses, but it's not going to be stopping the inflammatory reaction, which is the most key for patients that are dying. So coming into IL-6, IL-1 blockade, it is only specific cells that blocks, whereas corticosteroids block the most of the symptoms, most of these cytokines, protein synthesis, and prevent it. In our clinical experience, it's about 27 patients we treated. Almost all of them recovered. 30% of them are over 60. 6 patients have dyspnea of less than 94%. 10 patients have a cough and exertional dyspnea. And all these patients were, most of them were positive antigenically. Again, antibody-wise, they're almost 75% were negative. These were all treated with 1 to 2 milligrams per kg weight of steroids and azithromycin for secondary infection, paracetamol for fever. Most of these patients recovered with hydration. With this, I will stop my experience and I will I'll ask Dr. Meduri or the following speakers to give their experience, and most of them, they have done significant research work.
Suresh, can you, okay, thank you. Dr. Bijay, can you introduce Dr. Meduri, sir?
Yes, it's my pleasure to introduce Dr. Umberto Meduri, who was my professor at Memphis during training. And he's done pioneer work in ARDS, and he's going to shed some light. And it's good to see him and Ramesh. I trained with Ramesh in Chennai, both taking the stage today to conquer this inflammatory process. Dr. Meduri, the stage is yours.
Thank you. Can you hear me?
Yes.
Yes,
Oh, okay. I'm sorry. This is the first time I use Zoom to give a presentation.
oh.
So I'm a little bit awkward in what I'm going to be doing now. Let's see.
You can
Share screen. Now, let me know how much time I have.
No, go ahead, sir.
Okay. So first of all, I was very excited about what you just shared with us. And want to let you know something that, can you see the screen now?
Yes, you can make the full screen.
Okay. Actually, in Italy, an owner of 2 nursing homes sent to me and my colleague in Italy called Confalonieri, and I will show some of the work we have done together. In a letter, and he said, Dr. Confalonieri, I have to share this with you. I know you're doing a study on methylprednisolone in severe COVID. Because I heard about your study, we decided to treat all our nursing home patients that develop cough, fever, etc., as if it was an asthma exacerbation. and we have no deaths. And all the other nursing homes around us have deaths. So I think that somebody needs to contact nursing home owners and see if maybe this message can be sent to them. Let me go to my presentation. I distributed just now to Mayor, Dr. Ramesh, this article, The Rationale for Prolonged Corticosteroid Treatment in ARDS Caused by COVID-19. I have no conflict of interest, but I have academic bias. I love steroids and I make no money out of it. So in March 8, the USA Today wrote, too many coronavirus patients, too few ventilators. Outlook in the US could get bad quickly. Well, we know what happened. And what happened in the United States, especially in New York, is very similar to what happened in Northern Italy. And so I believe that any intervention that is directed at decreasing dependence of mechanical ventilation and mortality in COVID-19 patients also has a significant impact on public health. And I wish to add also national security. Now, this is a classic representation of what happened to our patient with a viral response in the first week. And then the patient start to have pulmonary symptoms that they are divided in stage 2A, stage 2B. Stage 2B is when the patient has hypoxia, and that's usually when we see the patient hospitalized with dyspnea to the hospital. And this is the phase in which the host inflammatory response manifests and goes up to shock, acute respiratory distress, etc. And the patient have manifestation of dysregulated inflammation, with an elevation in marker of systemic inflammation and abnormal coagulation. And the antiviral defenses at this point are exhausted as part of that exaggerated inflammatory response. So when we look at the laboratory markers of COVID-19 admitted to the hospital, we see an elevation in inflammatory markers and also chemokines and many other mediators and factors involved in coagulation that are very similar to the one that were previously reported in the literature with SARS, MERS, and non-viral ARDS. We see an elevation in acute phase reactant like C-reactive proteins and ferritin, and endothelial injury and coagulation with increase in D-dimer, INR, and a reduction in platelet count as a product of consumption at endothelial level. And the clinical outcome in this patient is related to progression, to ARDS or respiratory failure. In other words, the leading cause of death in COVID-19 patients admitted to the hospital is respiratory failure that has clinical characteristic and many histological characteristics they share with non-viral ARDS. Now, the dysregulated inflammation and coagulation that we see in COVID-19 is very similar to the one that we see in multifactorial ARDS. And in non-viral ARDS, there is strong experimental and also clinical evidence from randomized trials, both for animal studies and human studies, show that when you add prolonged methylprednisolone in comparison to a control, there is an effective downregulation of, of systemic and pulmonary inflammation, coagulation, and fibroproliferation that accelerate the resolution of the disease. In other words, as we see cytokines level and other markers coming down, we also see an improvement in lung injury score, in SOFA score, and other markers of organ dysfunction. Now, the computer tomography characteristics of ARDS, that is the ground glass appearance, is consistent with glucocorticoid or corticosteroid responsive disease. Similar applied to the histological manifestation of the disease, both in the early phase with highly membrane endothelial injury, lymphocytic interstitial infiltration, and in the late phase, we can see fibrin balls, we can see intraalveolar and bronchiolar cellular fibromyxoid exudating. In other words, we see the process going forward toward fibroproliferation. So those are shared also, with the exception of this, with non-viral ARDS. And those are corticosteroid responsive. So Before I go further, let me tell you what I'm going to discuss. I'm going to discuss about the findings of prolonged glucocorticoid treatment in non-viral ARDS. Why? Because I believe that the pathophysiology is similar to the one we see to COVID-19. And so what applies to non-viral ARDS may also apply to viral ARDS caused by COVID-19. I'm sorry, this goes too fast. And then we go also to a review of the WHO guidelines that I believe are founded on incomplete evidence. We're going to go through the large data sets of SARS and H1N1, indicating that actually corticosteroid treatment is associated, I'm sorry, with a significant reduction in mortality. Then we go to some initial study of COVID-19, guidelines from Europe, China, and Korea. And then we talk about what should be the recommendation of a preferred use of corticosteroids in COVID-19 patients. So let's go to non-viral ARDS. So this is most commonly caused by community-acquired pneumonia. What we're going to go over the data source, and those are 10 randomized studies, and I'm going to review the effect of treatment on inflammatory markers, on gas exchange, on duration of mechanical ventilation ICU stay. Very important, remember, what we want to do by decreasing inflammation is to achieve resolution of ARDS, improving gas exchange, decreasing duration of mechanical ventilation ICU stay. So that's the objective of our intervention with steroids. We're going to look on the reduction in hospital mortality that I like better than 60 days, 28 days. This is, I want to make sure the patient gets out of the hospital. So this is the best data. We're going to look into how much the patient is free from mechanical ventilation and from ICU at day 28. And then complication. There is this misunderstanding that corticosteroid treatment is associated with an increase in infection rate or other complications. That's not the case. And then we're going to look into the treatment protocol. We're going to look at different types of corticosteroids, what is the best timing of initiation, duration, and how to deliver corticosteroids, difference between bolus administration, which is common, and the one of an infusion. And then we talk about how to identify early infection and how to prevent glycemic variability. So let's go into the data. So this is the fun part. Do steroids work in ARDS, yes or no? Well, the data has completely changed as of February 7 of this year, when we have the largest randomized study ever published by Jesus Villar in Spain, involving 270 patients, in which he investigated dexamethasone and found a significant improvement in every parameter that was investigated. So we have 4 studies that investigate methylprednisolone. We have 5 studies that investigate hydrocortisone, and 1, the largest study that investigate dexamethasone, the one from Spain. The number of patients total is 1,093, 322 with methylprednisolone, 494 with hydrocortisone, and 277 largest studies from Spain. So that's the data set that we're going to review. Now, regarding the methylprednisolone, those are 4 randomized studies, but all the data sets were brought together and looked into one single analysis of individual patient data that was published 4 years ago, and this is extremely important data. And then we have the analysis from the Spanish study of Jesus Villar. So we're going to compare those two. This is very important to decide what drug to use and how treatment works. Now, this slide is important. We're going to look at the impact of treatment on reduction of systemic inflammation, improvement in gas exchange, reduction in mechanical ventilation, and reduction in ICU length of stay. And if you see the word yes, means that there is a statistical significant improvement. First, we're going to look at the 4 methylprednisolone study. Then we're going to look at the 5 hydrocortisone study. And finally, to the dexamethasone study. Now, this is the data from the 4 methylprednisolone study. The duration of treatment was 2 weeks to 32 days. Okay, and what you see is that there has been significant improvement in each one of those variables. When we look at the hydrocortisone study, there is a lack of report in few of them, but there are two failures to improve reduction in mechanical ventilation in two studies. The dexamethasone, there is an improvement in gas exchange, duration of mechanical ventilation, and ICU length of stay, but there is no report that did not measure C-reactive proteins or any cytokines over time. So the message that you get is that there is a consistent response, 100% and for all, but and 80% for reduction in mechanical ventilation. So we have 10 randomized studies that consistently show an excellent response in this important parameter. The message is that by reducing systemic inflammation, I achieve an improvement or an acceleration of the resolution of ARDS, gas exchange improved, reduction in duration of ventilation, and ICU stay. So far, so good. And we're gonna focus on the methylprednisolone IPDMA a little bit because that's important. So what about change in duration of mechanical ventilation or mechanical ventilation 3 days? And so the studies are very important. The difference in comparison to control in mechanical ventilation 3 days with methylprednisolone is 8.5 days. With hydrocortisone 4 days and almost 5 days with dexamethasone, quite impressive. What about reduction in duration of mechanical ventilation? Oh gosh, keep going forward. It's 10 days with methylprednisolone, is 5 days with dexamethasone. So what message I'm trying to convey to you is that so far the best response was with methylprednisolone. And this will bring us forward later on to the study from Wayne State University. So methylprednisolone almost double the rate of extubation of dexamethasone and hydrocortisone. Very, very important. So there is a reason for that. Now let's look at the hospital mortality, very important. So this is the overall hospital mortality of a 10 randomized study for patients treated before day 14. And what you see here is that a 30%, 33% relative reduction in hospital mortality. What about dexamethasone? We have a 34 reduction, so very similar to the global. This is the confidence interval, so it's significant, does not cross 1. What about hydrocortisone? We have a 20%, 23% reduction in mortality, but it crossed 1, so this is not significant. And what about methylprednisolone? Well, the relative reduction is exactly 49%, does not cross 1, and is highly significant. You need to treat 5 patients to save 1 life versus 7, 8 with dexamethasone. Although if you go to day 60, it becomes 6.5. So you need to treat 5 patients. So if you look across this, both in reduction of mechanical ventilation and in survival, the best data are obtained with methylprednisolone. And if you use it yearly, it goes down to 4.5, late 6. So 5, excellent results so far. Now, what about the risk of complication? So everybody keeps talking about the steroids increase the risk of complication, but when you look at the reference they apply to reference for the 1980s when steroids were used at a dosage of 120 milligram per kilogram, okay? The equivalent of prednisone, 10 milligram a day for 1 year, 365 days. So there was not a study, there was an intoxication of a patient, and that was associated with an increase in complication. But when you use the dose that we use now, 1 milligram per kilogram for a few weeks, there is none. If anything, what you see here for methylprednisolone, there is a reduction in the risk. And overall, there is a reduction of the risk. So glucocorticosteroid treatment used correctly in the dosage of 1 milligram plus minus for a few weeks, up to 3-4 weeks, is not associated with an increased risk of complication, of nosocomial infection. If anything, it's the opposite. Now, to summarize, what drug to use? Well, methylprednisolone is definitely superior to hydrocortisone. A bolus, why do we use a bolus? And I will go into the protocol later, is because when you bolus the patient with 80 milligram, instead to divide it with 40 milligram to 12 hours, you achieve rapidly saturation of the receptor, so you have an immediate effect You don't have to wait. Why to use an infusion? An infusion allows to achieve rapidly a steady state. Very important to get the pharmacological effect to be maximal. It's also associated with lesser glycemic variability. You don't have spiking blood sugar. And importantly, there is increased lung penetration. Let me open a small parenthesis. Which is the best drug for entrance into the lung and accumulation into the lung? It is methylprednisolone. That's why methylprednisolone for the last 30 years has been used invariably for inflammatory lung diseases. So this is very important. Now, the duration is approximately 24 days, but definitely should be superior to 7 days, at least for what is concerned non-viral ARDS. And I like to make that case also for viral ARDS. Dexamethasone is also very important, works very well, and the dose is used daily for 10 days in the Wheeler study and was very effective. What about tapering? I will not stop a drug. 30 to 35% of patients with systemic inflammation that is excessive, like the one of critical illness, if you stop a drug with a tapering, they have rebound. And this rebound is associated with the deterioration in organ dysfunction, and in many of them return to mechanical ventilation. Now, the FDA clearly states in the drug book for methylprednisolone and all the other steroids that there must be tapering. So tapering should be part of any patient. What about if I use it for only 4 days? If you use it for only 4 days, 30% of patients have adrenal insufficiency at day 30. So no, you have to taper steroids no matter what the duration is. Infection surveillance is important, but now that we have procalcitonin, monitor procalcitonin with the way to identify infection in the absence of fever in this patient. Now, this protocol that I'm showing here is the one developed by our group, and it's the protocol that is recommended after we look at a lot of things by the Society of Critical Care Medicine and also the one of Intensive Care Medicine in Europe, Task Force, published in 2017. Now, the bolus I explained, we have rapid saturation of the receptor. The infusion is very important to maintain steady state, is achieved, I apologize, by using the 80 milligram, that is the dose that we usually use, that is close to 1 milligram per kilogram of ethyl body weight, in 250 cc of saline, kept there at 10 cc an hour, okay? If a patient improves, we monitor C-reactive protein and all the other inflammatory markers, lung injury score, SOFA score. If a patient improves with a reduction in lung injury score 1 point, or PO2 filtration increased by 100, before day 14 is advanced to day 15. So in other words, you adjust your treatment to the basis response to minimize duration. That's very important. For most of the patients are extubated before day 7. They move to day 15 of treatment, where we continue with half a dose for 1 week, and then we go to the tapering at the end. So many people have a question, what is the reason of all this? The first part is to repress inflammation, very important. But what we are learning the last 10 years, that a moderate amount of steroids and a moderate amount of inflammation is necessary to resolve and restore. So if you want to bring rapidly lung function, anatomy and function back to normal, you should continue low dose methylprednisolone. And then in the last 6 days, you taper. And the reason for this to allow recovery of a hypothalamic pituitary axis. Now, I'm going to skip this slide so I don't bother you. But just to everybody knows that IL-6 correlated with outcome in COVID-19, both respiratory failure, patient that require ICU admission, et cetera, et cetera. And as you know, there are drug companies trying to push their own product to bring down IL-6. But what about methylprednisolone that has decreased significantly in the IL-6? Well, this is the data in early RDS from our group. This is the reduction, this is a randomized in comparison to control, okay? And this applies in overall early RDS, in ARDS called by infection, mainly pneumonia, and in fact in ARDS of pulmonary origin in general. So it is very effective. What about if you start later on? This is the patient with open bar placebo, closed bar methylprednisolone. There is no improvement in IL-6 up to the day of randomization. This is what happened when they get methylprednisolone. The message is methylprednisolone is highly effective in decreasing IL-6, one of the cytokines that correlates with outcome in COVID-19. So that's the message. Now let's go, if you want, I can skip this, but I want to go into a criticism of the WHO guidelines, that are frequently quoted not to use steroids. So the WHO made this recommendation. Given the lack of effectiveness and possible harm, made the decision not recommending the routine use of corticosteroids for the treatment of viral pneumonia outside clinical trials. I think this is a very dogmatic decision that has been criticized. I distribute the commentary that we sent, but actually it reached through the White House and other people, the WHO, and now the WHO is going through some second thinking. Now, how do they make this decision? So what evidence to support this? Only 4 publications. This is really amazing. One is a meta-analysis from Stockman, a poor meta-analysis actually, published in 2006, quite outdated. Another one was done as a meta-analysis from 2016 that was limited to only 10 studies. There are 40, 50 studies that involve less than 1,500 patients. And most of these studies did not report, okay, how they use steroids, why steroids were indicated, timing, dose, and duration. So just presence of steroids, yes, and they do an analysis. And then 2 retrospective observational studies in which there was no pre-designed study protocol involving 600 patients with H1N1 and 300 patients with MERS. And what the study found, that after they made adjustment for baseline imbalances and other time dependence confounders, there was no mortality benefit. In other words, this study did not find an increase in mortality, found no change in mortality. Now, they also quote frequently this study by Arabi, okay, is a MERS study in which they say the corticosteroid is associated with an increase in a reduction in viral clearance. So this is the most quoted study to say the steroids impact viral clearance. But what they did not mention that was true if treatment was less than 7 days, but was not true if treatment was more than 7 days. So it is very weird to face this. If treatment is long, there is not impact in clearance. If treatment is short, there is an impact. So this is important to know. There is question on their data. And that's it. That's all what they used to say not to use steroids. And so we have tens of thousands of patients that die with massive inflammation worldwide without being treated with an anti-inflammatory treatment. The message is important that what kills COVID-19 patients is dysregulated massive systemic inflammation. There is no evidence linking delayed viral clearance to worsen outcome in critically COVID-19 patients. So it is unlikely that if the delay in viral clearance would have a greater negative impact on outcome than the host cytokine storm. So that's why we need to concentrate on the host cytokine storm. Now, this is the study used by the WHO, which was also used in 2 letters to Lancet that are frequently quoted. The first letter was written, the first letter is by Richard Mattei in San Francisco. The second one by Russell that also included one of the members of the WHO that made the recommendation. And their recommendations are based on these meta-analysis, I apologize, okay, of only 10 studies. Now look at these 10 studies, and I'm gonna point out one thing. 6 of them, the one marked, do not report, okay? There is no report on the type of corticosteroid use or the dose use. Yes, they use this data to say the steroids don't work in SARS or H1N1 pneumonia. So very, very poor data. What they left out are large data sets that were available, okay, but were ignored. And this large data set I'm going to present you did a very important work. They adjusted for confounders that impact the outcome. In other words, patients that usually get steroids are the ones that deteriorated. So why don't I adjust for what are called time-dependent variables? In other words, events that occur after admission to the ICU that lead to the initiation of steroids. That usually is a deterioration of the patient. So they adjusted for that, and then they were smart enough to look into the type of corticosteroid that was used, timing of initiation, dose and duration. Why this is important? Because the information that we obtain from this large data set that we will apply, this is the information that we need to have some substance in how we use corticosteroids in COVID-19. So those 4 studies are extremely important. This is a very frequently quoted study from CHEST on a study of 400 patients, okay, with SARS pneumonia. And what they say is there is no improvement in mortality. But then they say, okay, why don't we look at the 152 patients? I apologize. I told you I'm new. 152 that have a severe form. And in the one that severe form, what they found, lower overall mortality, instant mortality, and shorter duration of hospitalization. And these, their Kaplan-Meier curve. This is methylprednisolone in this patient versus the control group that did not receive. This is the severe. So the message that this group tells you with SARS in severe cases seems to work. Then there is another larger study, 1,200 patients. And this study not only adjusted for all the confounders, but they look at the different type of steroids. They look at no steroids, prednisone, hydrocortisone, methylprednisolone, and post-dose or high-dose methylprednisolone. Long story, this was up to then the largest data set available. What they found, individual, the group receiving methylprednisolone, so we go back to methylprednisolone all over again, okay, confer lower mortality compared to no steroids. So among all these protocol of steroids, they say the methylprednisolone is the one associated in comparison to other steroids with the lower mortality. So we get 2 information, severe and methylprednisolone. Now we go to the largest data set. Now we talk about big stuff. So the 2 largest data studies that are never quoted by the WHO or other people that speaks against steroids, they evaluated time, dose, and duration of corticosteroids. And what they found is a significant reduction in mortality when we use the protocol that I showed you before on methylprednisolone that is recommended by the Society of Critical Care Medicine and in fact, and the Intensive Care Medicine Society that is European. So the largest study, what they did, they went to the data sets of China regarding SARS, and they looked at 5,300 patients. After they adjusted for confounders, they found the corticosteroid treatment was safe, number 1, to decrease the risk of death by how much? Almost 50%, by half. And where do you get the best results? Methylprednisolone 80 milligram. What I'm trying to tell you that what we see in non-viral ARDS and what we see in viral ARDS that will be confirmed later on in COVID is the same message. Methylprednisolone seems to see the drug at this dosage of approximately 1 milligram per kilogram of ideal body weight to work best. And I'll show you the data soon. Then let's go to the other study. This is H1N1, 2,100 patients, okay? Now, I'll show you the data later, but what they look into, when you look at those with a PO2 and FiO2 ratio less than 300, the one that we're interested into, okay, low to moderate dose corticosteroid decreased 30 days mortality by how much? 49%. So similar message, okay, SARS, H1N1, moderate dose of methylprednisolone, significant reduction in both 30-day and 60-day mortality. Let me show you now the largest data set. Okay, they did all the adjustment here. I'll spare you the detail. Okay, the risk of death dropped by 63% and 43% when you use 63% a dose of 80 milligram. 80 milligram, 63% reduction in mortality, okay? 43% if you go above to 100, double the dose, okay? Now look at the Kaplan-Meier curve. And what you see here is different dosage of methylprednisolone. 80 milligram, the best results. Look at the reduction in mortality. Look at the confidence interval here. 160 milligram, not too good. So you don't want to use too much of a high dose, okay? And this is 160 in between. So it looks like the dose that works best is the 80 milligram, okay? Now, let's look at the H1N1 study. This is the overall response, okay? The reduction in mortality is 68% with steroids, 14% with the non-steroids group. This is the group with the PO2 FiO2 ratio above 300, and there is no reduction. But when you look to the larger group with a PO2 FiO2 less than 300, there is a huge reduction in mortality from 20% to 80%, okay? So most of the improvement here is due to this group. So over again, the same message. PO2 FiO2 less than 300, okay? That pretty much is a patient that requires 4 liters per minute by nasal cannula, okay? There is a 50% reduction. Instead, when you use high dose steroids, there is no difference. So there is a dose that seems most effective. So that's the data, real data on SARS and H1N1 that we get when we look at the largest data set. Now we move to COVID-19. And I'm sorry to bring all that information back before, because I think the information on non-viral ARDS and on viral ARDS from largest randomized study, large data set, is essential to understand how we need to operate now. So this is the first published study in JAMA showing an improvement. When there is use methylprednisolone, there is a reduction in mortality. This is 201 patients. IS6, one again correlating with mortality. Sicker patient got steroids. They use the same protocol of the Society of Critical Care Medicine. So 84 developed ARDS, 50 got treatment, mortality 46%. 34 got treatment, mortality 62%. But I want to point out one thing here. What you see here is what happened. There is a nice reduction in mortality. Well, let's skip that. Let's say that overall, we don't go into many details. There was a reduction, but again, just an observational study. Then there are other studies showing that there is an improvement in PO2 FiO2. So I want to show, remember I made the case, reduction in inflammation, improvement in gas exchange, reduction in duration of mechanical ventilation, reduction in ICU stay, reduction in mortality. So this is data on 26 patients. They got methylprednisolone. In red is with methylprednisolone. In blue is before. And what you see is how PO2 FiO2 ratio improves after you give methylprednisolone. Okay, there is a nice improvement all throughout. Conclusion, what they found is that giving methylprednisolone was associated with improvement in gas exchange. Okay, there was only 1 out of 22 patients that progressed to intubation, and they found it was safe. And they also reported when they look at the SARS nucleic, when they test for SARS, that there was no difference. I forgot what day now, I'm sorry. In other words, methylprednisolone did not impact on decreasing viral clearance or resolution. The conclusion that the appropriate dose of methylprednisolone can effectively avoid invasive mechanical ventilation and decrease mortality in COVID-19. Then there is another study I want to show you just because they have a nice CAT scan view. They use the same protocol for 7 days, but then they adjusted the treatment duration to reduction of inflammation. And what you see here is how the PO2 the saturation improved with steroids much faster in compared to the control group. And here you see the effect of methylprednisolone in decreasing the ground glass appearance. instead of a delayed clearance in patients that don't receive methylprednisolone. And again, safe treatment. And then we go to the Wayne State University experience that was just presented 2 weeks ago. So Dr. Dragic Sorin from Advancia, that is a professor, computer science and associate dean at Wayne State University. What he found, he identified methylprednisolone among many other drugs tested to be the best one to improve, to impact on all the various components of the inflammatory coagulation and immune response in COVID-19. But then he brought up something also very important. He also tested many drugs, but among the steroids, he trusts prednisone, and also dexamethasone. And he found that those two were not effective, as effective. The most effective was methylprednisolone, and methylprednisolone was more effective than any other of the hundreds of drugs that they tested. And this led to a study that we'll present now, unless Dr. Ramesh wants to do it, but that's his study in essence. And what it shows is that after this information, they decide to implement a protocol investigating methylprednisolone prospectively in patients with COVID-19 severe pneumonia, 200 patients, and they found some positive response. So this is the study. It's a multi-center quasi-experimental study done at Henry Ford Health Services, and they had 132 patients that prospectively treated with methylprednisolone, and they look at retrospectively at the group of 81 patients before they implemented this technique, this protocol. But I need to point out that many of these patients also got steroids, okay? So we compare systematic implementation of a protocol versus treatment without a protocol, in which a good chunk of patients also got steroids. So the indication was you need 4 liters by nasal cannula. Again, this is similar to the severe SARS, less than 300, et cetera, et cetera. The dosage was half to 1 milligram per kilogram, okay, for a duration of 3 days. But to my understanding, many of the patients extending to more than 3 days. So this is the pre and post protocol. So corticosteroid was using 56% and then 68%. In the first 48 hours, receiving 12% versus 41%. The median time to initiation from development severe SARS was 5 days versus 2. So we talk about earlier implementation and larger implementation. And the median dose was about 40 milligram, okay, which I believe is a small dose, low dose, but anyway, this still gives good results. And the median duration was 3 days. So let's see what happened. The composite score include either one of the following: death, mechanical ventilation, or a transfer to the intensive care unit. And what they found, if they have any of these, was 54% of patients in the old group and 35. So decreased significantly the composite score. They decreased significantly death, half of it, okay? They decrease significantly the need for mechanical ventilation, and they decrease significantly also transfer to the ICU that will go along with this. Secondary outcome, there was a reduction of 1 day in median duration of mechanical ventilation, and there was a reduction of 3 days in the median duration of hospital stay. So what is telling you is that when applied consistently methylprednisolone, there are improvements, and some are significant, especially the one in the primary outcome. Now we go to the guidelines. Briefly, I want to let you know that now steroids is part of a guideline of China, Italy, Korea, and many other countries. So they're disregarding what the WHO says. So let me go now and summarize what I told you. 10 randomized study in non-viral, safe, sizable reduction in duration of mechanical ventilation, ICU length of stay, mortality. In viral pneumonia, studies involving essentially 12,000 patients, safe, decreased mortality in severe SARS, best response with methylprednisolone, 80 milligram, and the duration of weeks, not days. H1N1 safe and decreased mortality for those with a PO2 FiO2 less than 300, like the study of Dr. Ramesh. And then in COVID-19, there is limited, but I think encouraging data. I'm aware of other studies that I cannot share with you because I'm a reviewer, and I think things are going in the right direction. So this is the recommendation. If you have somebody that come with a PO2 FiO2 ratio less than 300, or they're on 4 liters, our recommendation is 80 milligram per kilogram is okay. Monitor daily gas exchange, C-reactive protein, D-dimer, ferritin, and procalcitonin, etc. If there is no response with your treatment in 3 or 4 days, consider doubling the dose. This is very important. Some people have glucocorticoid resistance, especially smoker, obesity, patients that have cirrhosis, etc. I also recommend, and this is part of this group recommendation, to add vitamins, vitamin C, thiamine, and vitamin D. And those are very, very important to improve corticosteroid function and mitochondrial function, which is essential to provide the energy to get all this done, okay? If a patient is on mechanical ventilation for more than 7 days, consider infection surveillance with non-bronchoscopic BL to avoid the pneumonia in the absence of fever, or just monitor procalcitonin. If that is elevated, work out for infection and start empiric antibiotic treatment. Now, this is a study from Italy. I just want to let you know that are similar to the criteria that we discussed, PO2 FiO2 ratio less than 250, or CRP more than 100. They use the protocol that I just discussed, okay? And the results of the study is completed, okay? And the results of the study will be submitted for publication in the next week to 10 days, okay? But this protocol, I can tell you, is worthwhile using, and that's what I can tell you, okay? And this is essentially the protocol. Bolus, infusion with 80 milligram, and then if you reach this criteria, you go down to 40 milligram, okay, 40 milligram, and that's an improvement in PO2 FiO2 ratio than 300 or CRP less than 20. And then if you go, once you get for this dose to criteria B, we'll go further. So it's a duration and dosage directed by the response of gas exchange and the response of inflammatory markers. Okay, and then I will now go, do I have 3 minutes for HLH?
I think, can we answer when we ask the question, sir?
Yeah, why don't we go to the questions? Yeah, that'd be fine.
Let me introduce Dr. Corey. He's the next speaker. Thank you so much, Dr. Maduri. This topic will be recorded and shared with the rest of the world. This is excellent, sir. I'm going to introduce Dr. Pierre Corey. He's a pulmonary and critical care medicine, a recognized national leader in critical care ultrasonography, having served director of the advanced course sponsored by the American College of Chest Physicians, served as the senior editor of the first comprehensive textbook and point of care ultrasonography. He spoke to the U.S. Senate Committee on Homeland Security, Government Affairs on May 6th. We shared his video to everyone. Dr. Corey, take away.
Okay, thank you. Thanks for inviting me. And I just want to say how much I enjoyed Dr. Maduri's presentation. I mean, he really carefully took us through what is some very granular evidence for the role of corticosteroids in not only ARDS, but in inflammatory diseases. I also listened very carefully to Dr. Suresh's presentation of his outpatient. And I really actually want to focus on that case presentation because I'm going to tell you where my sort of mindset is right now on COVID-19. So let's be clear. I'm a pulmonologist as well as an intensivist. And when I'm in the ICU, which I've been in for the last 5 weeks, I've seen patients come in really critically ill with advanced lung failure, lots of inflammation, and pretty advanced lung disease. But when you see patients early on, like Dr. Suresh did, in mild forms of inflammation, Here's my great insight that I want to share with you all. And it's actually a paper that I'm writing right now. It's an editorial that I want to try to publish in the New England Journal. But here's my take, is that this virus is causing a pandemic of what's called secondary organizing pneumonia. Now, if you're not a pulmonologist, you might not understand what organizing pneumonia is. So let me bring you back to the old days. If everyone remembers the terms BOOP, right? So BOOP, right? Bronchiolitis obliterans with organizing pneumonia. You know, that's an older term. We now use COP, which is cryptogenic organizing pneumonia. Now, cryptogenic organizing pneumonia is a pattern of inflammation in the lung for which we don't know the cause. But more common is what's called secondary organizing pneumonia, and that's very commonly associated with drug injury as well as viruses and different bacteria. And what the radiologists have been publishing now for 2 months, and this is my great insight into COVID, is that the radiologists, so in the journal Radiology 2 months ago, and actually in a number of radiology journals, they have reviewed the CAT scan findings of all the early manifestations of COVID, and they're all saying that the radiographic pattern is one of an organizing pneumonia. Now, organizing pneumonia to me as a pulmonologist has always bothered me, because anytime you use the word pneumonia, everybody thinks it's an infection. But the actual term organizing pneumonia describes an inflammatory host response, just like Dr. Suresh mentioned, just like Dr. Maduri mentioned, which is it's this inflammatory response. So you can go as far as ARDS or diffuse alveolar damage, but the inciting event seems to be what's called an organizing pneumonia, which is this fibroproliferation in the alveoli. The key thing that I want everyone to notice is that organizing pneumonia is exquisitely responsive to corticosteroids. And I really listened very carefully to Dr. Suresh's case, in that he started steroids on an outpatient who had bilateral infiltrates and a mild reduction in oxygen saturation. It's my assertion that the patient that he treated had early secondary organizing pneumonia incited by this virus. And I think I actually think COVID is a pandemic of secondary organizing pneumonia, which we know that is a disease that is exquisitely responsive to corticosteroids. And I got to tell you, the doses that he used, the duration that he used, which is he's treated a number of patients for 1 to 3 weeks, that's excellent. You know, traditionally organizing pneumonia, when it's COP or cryptogenic, you know, the textbooks are up to date, will say 4 to 8 weeks. But when it's secondary, you usually can get away with shorter courses. And the main thing that I want to say is that you need to start early, and you need to follow your dosing with the clinical presentation of the patient, which is to say, if they're getting better, great, keep on with your dose, taper slowly. If they recur or the symptoms worsen, increase. If the dose that you choose, and a lot of us are doing like 1 mg per kg in divided doses. I think Dr. Suresh did that. He did sort of 40 milligrams BID. I think that's great. But what I'm seeing in the ICU is I'm seeing some patients who are failing those modest doses, and we're finding that we're actually able to rescue patients with very high doses. If you look at up to date for organizing pneumonia, what they call fulminant disease, meaning crashing onto a ventilator or rapidly progressive, you know what the experts say? It's all based on case reports and clinical experience, but they'll say you need 125 Q6 or 1 gram a day. All I can tell you guys, I'm sorry I can't give you a big study, but my experiences over the last 4 to 5 weeks, I'm in an ICU in New York City, and my challenge is I've been taking care of what I would call chronic COVIDs. I've been taking care of patients who are in their first, second, or third week on a ventilator, and many of them are irrecoverable. But those who are a little bit earlier on the disease, in this past week, I've been doing pulse dose steroids, and I've seen pretty dramatic effects. And so I just want to reiterate that I really think that the SARS-CoV causes significant amounts of organizing pneumonia, which is a particularly steroid responsive disease. I don't know what the right dose is. I like that Dr. Maduri in his erudite review of all the studies in the prior pandemics, it seems like 80 milligrams a day of methylprednisolone is the right dose. And I think I totally agree with that. However, if your patient isn't getting better, I think you need to escalate doses as tolerated. If they're doing well, you can taper slowly. But we need to be clinicians. We need to follow our patients. I don't know that every patient knows what dose they need. And so I'm just going to say in the last few weeks, I've been really struggling with my patients. But over the last week, I just sort of, I respond to my patients, I escalate as tolerated, and I wean or I taper. But the key thing is that I think we need to maintain these steroids for longer. Just like Dr. Maduri said, what he's always promoted in ARDS patients, you know, in organizing pneumonia, if you look at the studies, they generally treat for 4 to 8 weeks. I don't know that it's necessary in SARS-CoV, but I do think that they need to be followed carefully. You can taper slowly, but if you see any recurrence or worsening in oxygenation or symptoms, you need to go back up to your normal dose. And so I just want to finish by saying that I'm working right now on a paper. It's actually an editorial where we're submitting it to the New England Journal of Medicine, and I'm writing it with one of the top chest radiologists in the world. And the reason why is because I connected with him is because he's one of the expert panel who 2 months ago was saying that the predominant pattern of lung injury in early COVID is organizing pneumonia. Now, I'm talking about, you know, for instance, if you look at Dr. Suresh's case, where he talks about the bilateral pulmonary infiltrates and the mild hypoxemia, that's organizing pneumonia. Once you don't treat that or they get worse and they get into the ICU, you can see any number of forms of lung injury, such as diffuse alveolar damage and ARDS. But I think if we treat early and quickly, just like Dr. Suresh did with his patient, you can avert the deterioration and tragedy, which is this ARDS. And the other thing that we haven't published on yet, and again, it's going to be a while before we do, but we're seeing these late phase CAT scans of these patients 2 or 3 weeks in. Many of them end up into this fibrotic NSIP. They're getting very quickly fibrosed, and it's very hard to recover them. So the thing that I want to just finish on is saying that if you're going to use steroids, think of it in terms of targeting secondary organizing pneumonia initiated by the virus, and you want to use it early, and you want to titrate it to symptoms. If they do well, great, you can taper. If they don't, you need to escalate. And I just want to say I've had a number of successes with very high doses with these patients. I don't know why, but this disease seems to trigger tons of inflammation, and you really need to be a good clinician and follow along with your patient. I'm going to stop there.
Thank you, Dr. Corey. Dr. Vijay, can you introduce Ramesh, sir?
Well, Ramesh is my colleague. We trained in Chennai together several years ago. And the early part of when all these things was happening, we are on this chat group, and Ramesh was interested in trying, you know, and he's going to share his experience. But when you get a chance, Ramesh, I would also ask you, what made you stumble on steroids and when there were so many other alternatives? And you can answer that whenever you. And it's my pleasure and great privilege to introduce Mayur Ramesh to you. Stage is yours, Mayur.
Thank you. You know, following the footsteps of giants like Dr. Maduri and Dr. Corey, so I'm going to keep it simple because they've already explained, and Dr. Maduri explained my study better than what I would explain my study. So I was thankful for how well he explained and how well he laid the foundation for the role of steroids. So I'm just going to sort of relate my story a little bit and then quickly show something minimal, and then I'm done for questions. So since Bijoy asked me, Bijoy is my classmate from medical school and one of the brightest stars of pulmonary critical care medicine that I know of. Very bright, very insightful person. And I'm also, looks like he's been well trained by Dr. Maduri. So getting back into this story, on 3/10, we had the first case, March the 10th, we had the first case of COVID that hit Henry Ford Hospital in Detroit, Michigan. And then I sort of ad hoc started the COVID management task force, where it was just me and my fellow. We didn't have any specific management strategy. All we had was Kaletra, which is lopinavir, ribavirin combination, along with lopinavir, ritonavir, and ribavirin. And then we had no immune modulatory strategy. As you very well know, there is the early phase of the disease, which is the viral phase, followed by the immune modulatory phase. So we didn't have any good options at the point of time, and all the guidelines said, do not use steroids, do not use, pretty much we have nothing at that point of time. We had compassionate use of remdesivir. That's the only drug we had at that point of time, and couldn't be used for every single patient. We could not get into many of the clinical trials because they were already fully engaged, because so that's where we stood. Come 3/16, chaos hits. The entire hospital becomes suddenly chaotic with an enormous surge in the number of COVID patients. And we started getting 15, 20 code blue arrests a day, several people getting into the ICU, and obviously people dying. Things were completely chaotic. There was a fear that was setting into the healthcare system. They were worried that we're going to be the next New York City. And so I started, by background, I'm a transplant infectious disease guy. My background is immunology. So looking at the immunobiology and the data that's coming out of China, I felt it clearly what is happening, as Dr. Maduri explained. It's the innate immune response that is being hyperactivated at this point of time. And if you look at the cytokine responses that comes there as well, it's clearly ushered with the activated macrophage and the appropriate cytokines that are getting released. So it made sense to use, because we use cytokine storms for other disease processes, and we clearly use steroids in that setting. So why shouldn't we be using steroids? So I just wanted to make sure that the fear of prolonged viral shedding is not there. So I went back, looked at data and what is being presented in the Chinese literature, and clearly that signal was not there. The signal that was present seems to be, if any, of something that is beneficial. So the problem is, the only way I'm going to agree, the system, I work for a large healthcare system, for the system to agree to that is I need people to back me up. And the main people are the pulmonary critical care people. So as a single guy, I went in with my pharmacy team and roped in a whole bunch of pulmonary critical care doctors. And this was on 3/19. And I told them, you know what? If we keep on going like this, people are going to die. We have to do something about this. And so we decided we will move on. And I asked them, can you just give me 3 days of methylprednisolone? That's what I said. So that's, if you wonder why the three things started, it was just 3 days. So people will be, people won't get too worried about methylprednisolone. So even though we wrote it as 0.5 milligram to 1 milligram per kilogram, and predominantly everybody got at least 1 milligram per kilogram, it's equivalent to 40 milligrams of methylprednisolone twice a day intravenously, like what Dr. Maduri said. So that's what the majority of the dosing was. And clearly we understood that methylprednisolone is a better glucocorticoid than the other agent. So that's why we chose if you wonder why we chose methylprednisolone, so that's what we did. So we implemented the protocol officially on 3/20, and literally in less than 72 hours, the codes disappeared. Codes disappeared, people started getting better, extubated, people started getting released home, and things. So when I started the signal, we immediately realized we should do a quasi-experimental study of pre versus post, which was well described by Dr. Maduri as to what happened in our study thing. So I'm just going to temporarily share my screen to show you the 14-day mortality. We also have 30-day mortality in a Kaplan-Meier, and clearly the curve shifts. So I'm just going to show you that for just 1 second. I apologize, I take a second. So if you look at the Kaplan-Meier curve, and you can clearly see very early in the game, like about day 3 or so, the Kaplan-Meier curve starts shifting away, and that is clear compared to the blue one is the steroid protocol, and the red one is the pre-protocol, which is very little steroid used. And if you look at the type of steroid used, it was mostly for COPD in the pre-protocol, and they also used it very late in the game in case they get intubated or so. So, and then the 30-day mortality Kaplan-Meier curve is under publication. That's why I couldn't show it to you. So that Kaplan-Meier also shifts drastically like this. That publication is part of the Dr. Soren Drakji's team, where we gave our clinical data for them to publish at this point. So we actually started doing this independent of anybody. And then eventually, what I did is within about a week to 10 days, I had to disseminate this information since what we saw. So we disseminated this information to several centers through friends, basically. And since they trust me, so about 15, 20 centers, literally 1 to 10 days after we did this, they called us back and said that their chaos became calm as well. And so we started seeing dramatic benefit. So you could argue that that is part of some sort of external validity, meaning that is reproducible. What you saw here is actually reproducible in other centers. But the important thing is I told these centers to actually start publishing their information. So if you add, yes, our study is not a randomized study. It's not a randomized double-blinded placebo-controlled study. And in the time of pandemics, all you can do is a pragmatic or a real-world study that you can do the best you can. So, so knowing this as an information, if more studies come through, then you're going to shift the needle from disbelief to more of a belief, and in terms of trying to use it. So, and you clearly saw Dr. Maduri's data in terms of what he did and stuff like that. So, and before I stop, I just want to show you just a little bit more in terms of this curve, and I would encourage you to go to this mcric.org and look at this review of our own paper written by a critical care doc name of Joe Farkas. An amazing review, very appropriate review. So what he's showing in his review is can clearly see the early phase is viremia, which is about 1 week time. And then around about the second week mark is when the inflammation starts kicking in. So if you act too late, which is close to the 2 week mark, you're not going to get much benefit. Your benefit is going to be delayed, and the patient is going to be stuck in the hospital for a long time with delayed recovery time and maybe death if this one. But if you start them early and stuff like that, you're going to get benefit. So now, to finish my talk, what I would say is, what is early? What is early is when you develop exertional hypoxia. This is a disease almost like pneumocystis. If you remember pneumocystis times, if you take pulse ox at rest, the pulse oximeter will look normal. But if you exert them, it drops like a rock. And there is a dissociation between the partial pressure of oxygenation as compared to SaO2. So it's very important to remember that you do a simple maneuver of exertional shortness of breath and do an exertion, make them walk and develop and check a pulse ox, which is what we implemented in our ER triage system very early in the game. So we prevented ER readmissions at this point of time. And the more important message, which Dr. Corey presented in his Senate hearing, is very clearly is that you want these patients, to be presenting early, not late. If you present late beyond the 2 week mark of your symptom onset, then what is going to happen is that you're not going to help them that well. So it's that important that the message is sent across is the patient should present close to that early onset of symptoms, which is about the 7th day, 8th day, 9th day, somewhere in that ballpark, ideally should be coming into the hospital. Second is they need to be started on an appropriate dose of steroids, if such is the case, meaning 1 milligrams of per kilogram of methylprednisolone approximately comes to 40 milligrams Q12 intravenously, and then management strategy based on how they respond in terms of duration and stuff like that. So that's where I stand. Thank you,
Ramesh. I really appreciate it. Thank you, all those panelists, and we'll go to the question and answer. One other question for Dr. Suresh is you were giving steroids earlier, and a lot of people have a question about viral replication. I think Dr. Mayuri has answered that's not an issue, but can you answer, sir, about viral replication, your concern?
No, and Dr. Jara, the question that we have with the viral replication, we don't know because the steroids that we are using, they block the protein synthesis. If you remember, virus is, unless it has an envelope or protein envelope and a spike protein, it is not going to be any, it is not going to be infective. Remember, the viral RNA has to enter into the cell through the spike protein from the protein. Now, the steroids will stop, potentially, the protein synthesis. So whether the viral capsule is produced or not, we don't know. What we are testing in the viral is just RNA. The RNA itself is infective or not, I don't think we have any studies. Nobody has proven it. So the question of viral persistence maybe, is it just RNA molecules that we are testing, or is it a complete virus with capsid? Until we know the answer, it's very difficult to calculate what it is going to be. So the implication is now the main problem here is inflammation. To preventing the inflammation is more critical rather than the infection. If you remember, in this case, the infection, the virus is not killing the patient. It is the inflammation that is killing the patient.
Dr. Vijay, thank you so much, Dr. Suresh. Dr. Vijay, you have questions for our panel?
Yes, this is a question for Umberto. Dr. Meduri, there was Zygris then, it was a big competition, and then it fell by the wayside. And today we have remdesivir and other expensive medications. You think it's the economics that's driving the popularity? And if steroids were expensive, would it have been a standard of care?
If steroids cost, oh, excuse me, can you
Yeah,
hear me?
sir.
Oh,
Go
yeah.
ahead, sir.
Yes, so if steroids cost $1,000 a day, believe me, everybody will be using it. There will be enough information, enough on the news that is a wonder drug. It is a wonder drug. It's part of creation. That's what we are made. Steroids are the one that constantly adjust during the daytime to allow us to be in a homeostatic state. And they are the most important one when there is a life-threatening disease. And you know the story of activating protein C and steroids, okay? There are, I think the same thing goes on now. If you look at the news, there is no news that mentions the word anti-inflammatory treatment in a massive inflammatory disease. None in the news. It's not mentioned because the people that are paid, the public relation people paid by the drug company, promote their own product so that the market goes up and down, okay, based on whatever type of propaganda you're able to get out there. I spoke with some of my best friends, smart people in Italy during this epidemic. They refused to use steroids. They refused to use steroids based on WHO, but they will use something that blocks IL-6 or IL-1. It's amazing. They cost thousands of dollars that you usually use only by an immunologist.
Thank you, sir. The other question, this question, Dr. Corey. Now, Dr. Suresh said, and we as allergists believe early steroids, we're going to write a letter to Governor of Michigan with numbers, at least 60 years or older. Should we have outpatient protocol checking the lab test and X-ray and starting the steroids in third or fourth day? Can you comment on Dr. Corey?
Yeah, I don't know that I fully understood the question. Is the question about whether to start steroids in an outpatient?
Outpatient as a study. We do a study as an outpatient to check like if I have a COVID, if third day I have trouble symptoms, can I go to the lab, get the numbers, get a chest X-ray early, start the steroids? So that kind of a nursing home patient, 80 years old.
So let me give you my general impression, and I can't tell you that I have the best answer or a very data-informed answer, but I will tell you this: I think it's reasonable to start steroids in someone with signs of organ dysfunction. So if the oxygen saturation is low or they're short of breath at rest, I think that's when the time you should start steroids. I think that's when the inflammatory response is actually causing organ dysfunction. If you're just having fever, you're feeling poorly, you've fallen ill, that's not. You know, we're trying to divide this disease conceptually, and we don't know the exact cut point between the viral replicative phase and the host response. You know, Umberto spoke very well. ARDS is a massive host response to an injury. I've been talking about organizing pneumonia, which is another host response to injury. And that's when the anti-inflammatories need to be started, not early on when the virus is attacking you. I don't know that we're going to get it perfectly, but for me, if you're short of breath at rest or you have a low oxygen saturation, that seems reasonable to start. Dr. Suresh's case, that's what he did. He had an outpatient, 80 years old, whose saturations were 90 to 91%, and that's when he started it. And I have to tell you, he managed that patient well. He averted the trajectory to the ICU to worsening, and I think he intervened early on what was probably an inflammatory organizing pneumonia pattern of injury.
In Michigan, the numbers are if somebody 80 years or older get COVID positive, 1 in 3 are dying. And 70 to 80, 1 in 4 are dying. That's what the number I had in my slide. You can go to the Michigan. That's why those patients, at least nursing homes taken like a military type, then following them closely, we could have prevented half of these. That's what we're thinking to present to the case to the governor.
No, I agree with you to start earlier. I don't think you have anything to lose when you look at the data of 25, 30% mortality.
Yes, sir.
I mean, this is astronomical.
Yes.
I mean, so what is the risk? The risk that you have some delayed viral clearance and we don't know if there's any significance. I mean, but I love the concept of desaturation with exercise. I mean, that's really beautiful. I mean, I can really detect early a patient that is going to progress. And I think if you apply that and then you start steroids, you make a case.
So that's what we're going to write a few days from now. We already have governor's letters goes, and then somebody need to take in charge of this, otherwise it won't move. And that's my concern.
Can I say one thing? The data that 1 in 3 or 1 in 4 are dying from the disease with a positive test, I just want to say that's news to me. I've been following this carefully. Some of the worst outcomes are in New York, where the mortality of a positive test is almost 9%. So if you have a positive test in New York, it's about 8.7% chance that you're going to die. That's of positive tests. So the idea that 1/3 to 1/4 are dying in Michigan, it is not, that's not data that's known to me.
80
now,
years or older. 80 years or older.
Oh, 80 years or older, that's different. Yeah.
70 to 80 is 1 in 4. 60 to 70 is 1 in 10. But 80
yes, exactly. Okay, I understand. So for elderly patients, yeah, I'm going to agree with Umberto. I don't know what to do with those. That's a very high risk category and probably going to be err on the side of treatment rather than supportive care. Because I have to tell you, that's been my problem with this whole pandemic is so many people have been advocating supportive care only, and it's failed miserably. We've been seeing morbidity and mortality that we've never seen before. And so I would favor in those patients to treat more aggressively.
If I may say, Dr. Corey, one of the issues that we are facing, especially the recent last week, in the last couple of days, the studies coming in is even the positive, the PCR is only 70% of the positive, and it goes down after 4th day or 5th day, it is going down to 60% positivity. So the 40% of the people we are missing, even with the PCR. So I'm mainly relying on the clinical aspect that when they're having fever, shortness of breath, and hypoxemia.
And I support you.
Test is positive or not.
I totally agree with everything you're saying. You know, you can't rely on tests. You have to use your clinical judgment. And if you find someone with a febrile illness who's doing poorly, I think you have to assume they have COVID right now. And you're not going to do them any harm.
if
And
I may
also-
say something,
Go
to Dr. Maduri's point, is that early in the game, there was at least 20% readmissions from our ER. So very quickly, we walked into our triage system. It's a very unique triage model where I wandered like a patient, I walked in like a patient, and very quickly realized that all they were doing is resting pulse ox. So all I did is to change their parameters because it's a tent. And so it was easy for them to do an ambulatory pulse ox. It's not a 6-minute ambulation. All you need to do is like a minute or two ambulation right there while they're waiting, and they did the ambulation, and we are able to reduce the readmissions from the ER. That data is being analyzed at this point of time, but clearly the readmissions from the ER were reduced purely because of that one simple parameter of exertional hypoxia.
And also I'll add to this, of the people who died in Michigan, this is the Michigan website, 40% are 80 years or older, 40% died are 80 years older. So if we can able to concentrate on these parameters, when we can reduce the fear of death, then only we can move on, because we're going to live with this thing for 2 years or whatever.
Yeah, I recommend that you write a protocol, you institutionalize that, and the governor or somebody else provide the support for doing this research.
Okay.
Because it has a major impact. 1/3 of the deaths in Italy, I'm Italian, okay, they're in nursing homes. I mean, it's really dramatic what happened. I mean, it's like a concentration camp now in nursing home.
Yes. Dr. Vijay, any other questions? We have some
How
other.
does steroids impact the coagulation pathway? You know, because there's clotting.
yeah, we
bleeding.
have data. Oh, I'm sorry. You ask me?
Yes.
Oh, yes. So the coagulation cascade is pretty much part of inflammatory response, and all the clotting that you see is the result of what is a panendothelitis. In other words, there is endothelial damage and endothelial cell activation and injury all throughout. So we have data showing that in randomized trial, all these parameters of the clotting cascade improve when you use steroids, and that you have evidence of repair of the endothelial injury with decreased transendothelial migration. So it's important. So when you use corticosteroids, you don't treat that just inflammation. You treat the overall host response, which include also clotting and the inhibition of fibrinolysis. Fibrinolysis is inhibited during inflammatory response.
May I add to what Dr. Maduri said? Here, it's not only that we are finding now there are some of the protein or proteolytic enzymes that are working out in the furins that are working in uncoupling the protein folding. If the protein folding is uncoupling, the proteins are dysfunctional. So some of these coagulopathies, as well as hypoxemia, which is really unexplained hypoxemia. These are proteins that are uncoupling, straighten up, in Golgi apparatus, the oxygenation is not properly carrying. So there is a lot more that we don't know about this disease, and a lot more we don't know what the inflammation is causing. I think the key is because of this, all these inflammatory cytokines, chemokines, adhesion molecules, and some more protein molecules that we don't know are at once acting into. So just treating one cytokine or two cytokines is not going to cause any relief to the patient. No. So you have to treat it massively. I think at this time, unless steroids, there are no other drug that is available that we know of that controls all these inflammatory markers.
If you if you put a drop of steroids on an epithelial cells or an hepatocyte cells, you have 2,000 genes activated. This is in normal, without nothing, just drop it, okay? So steroids regulate much of the cytokines and everything else that you see. And it's a huge response. It's not just the few that we measure, it's astronomical.
So in the study that is under review in Nature at this point of time, which is by Dr. Dragchi's team, what they did is they looked at all the, they looked at cell lines with infection with SARS-CoV, with influenza and RSV. and looked at what are the genes that are getting activated and stuff like that. And using the genomic data, transcriptomic data, they used a biopathway analysis. So it's like an artificial intelligence pathway analysis model. So when they did that, and they looked at several different drugs that are repurposed, that are available. They found first they found several different inflammatory pathways, and they are predominantly innate inflammatory pathways, or the interface between innate immune system and the adaptive immune system. So that is what is profoundly elevated or enhanced. Those pathways are enhanced. And the number one drug that targets all the pathway is methylprednisolone by far. Not prednisone, not dexamethasone. They do it. I'm not saying they don't, but far lower and clearly. And then when you look at other specific targeted medications, they clearly come way down the list at this point of time. So it is when there is overwhelming response, you seem like you need a medication that targets the most. And that is why Medrol was chosen. And so independently, he has identified something. Independently, studies have been done clinically from us, for example, and other places. And it is combining together, and it seems like it works out.
Dr. Suresh, can you?
Hey, Meyer, can I just say one thing? I just want to jump on Meyer's point, which is Dr. Meduri did such a nice, careful exploration about all the data, in ARDS with the different glucocorticoid agents. And, he's showing that the clinical data is suggesting that methylprednisolone is the most effective. It reaches the highest concentrations in the lung. So for lung injuries, it seems to be the most effective. And then what Meyer was just saying, which is that, the Dragon6 study, it's really interesting. It seems like that is the most effective drug. And so not only from longstanding clinical data, but for more modern transcriptional genomics data, it seems like that's the one to use. And I have to say, I'm in New York, and I'm at a hospital, and I'm seeing tons of patients coming to me from the wards. I just want to tell you guys, they're coming to me after being treated with the DEXA ARDS protocol. Now, I don't want to put down that protocol, but they've been on the floors. They're getting 20 milligrams of dexamethasone for 5 days, and then 10 milligrams for 5 days, and then they're stopping. It makes no sense to me. They're on a protocol in which the dose is reduced while they're still ill, and then it's stopped while they're still ill. And then they crash into my ICU on a ventilator. And I look back and I wish, as per Dr. Meduri, they had been treated with methylprednisolone and they had been either titrated up or down corresponding to how they did. It's strange that people are following protocols from studies that don't really make sense to manage the disease. We all know if we're going to manage an asthmatic, if they're still wheezing in a severe asthma attack, we don't decrease the dose. We sort of match our dosing to their symptoms. And I just got to tell you, maybe I'm in a weird place. I'm in New York, but I've just been seeing very odd management on the hospital wards, which doesn't make sense to me. I really think that we should come up with a good, strong dose, escalate as needed, and de-escalate as needed. That's all I'm going to say.
Absolutely.
There's a question about, I think it's already, we have, I think 1 hour for 10 minutes. We'll ask this question. The cytokine filters treatment, any role in here? Cytokine filter, anything?
I have some experience that someone else does.
Yeah, there's a clinical trial that is ongoing using like a hemodialysis-based model called cytokine filter. And I know that Henry Ford may join, and not through me, through the nephrologist. So it's possible that we may be a site as well. So it is literally trying to filter out the offending molecules. But I'm sure that we need other elements. I don't know whether they'll be successful at this point.
Yeah, I actually have some personal experience because as the COVID was coming when I was at my institution, which is the University of Wisconsin, I understood that they were going into cytokine storm and these hyperinflamed states. And I actually partnered with my nephrologist We got some cytokine filters. One of my nephrologists had some experience with the cytosorb filter, and actually used it on our first like maybe 5 or 10 patients who developed renal failure. We used the cytokine filter. All I can tell you is this. There's no really great clinical data. All I can tell you is that their inflammatory markers skyrocketed down after we used it. Like I had someone with a ferritin of 25,000. After a 12-hour run with the filter, it went down to 10,000 and then 5,000. And similarly, the CRP. I don't know that I have enough data or experience. All I know is it seemed to reduce the level of inflammation, but I can't give you good clinical outcomes related to it. It has a good theoretic rationale, but we need more clinical data on it.
May I add to Dr. Corey's comment? The cytokine filter, again, we are thinking in the wrong way. Cytokines, not only the cytokines, there are other molecules that are causing the inflammatory, the chemokines. They're more smaller molecules than the cytokines. They're increasingly elevated in these patients. So I'm not sure whether just one part of the filtering or one part of addressing is going to result any significant improvement.
Sure.
Plus, you have to put a catheter, an invasive procedure, and the time and the cumbersome nature of that.
Sure. I think we're 1.5 hours. Can we ask for closing statements? Then, Doctor, do you have any other questions, Dr. Vijay?
Oh, I'm good.
Okay. Sir, Dr. Maduri, can you give us any closing statements, sir?
Oh, what can I tell you? It was a pleasure. Really, it's so good to see colleagues, that are interested in this and working hard to save patients' lives. It was a great exchange. I learned a lot.
Oh, thank you so much.
Pierre, we need to get in touch more regarding your secondary organizing pneumonia. I think you got something there, and I think I'll get back in touch with you.
Oh,
it was a pleasure. Thank you. Keep working hard.
Oh, yeah.
In Michigan, generate good data. We need data out there.
And also, we a lot of people came from India too, because in India we don't have cytokine blocker. We don't have $5,000. We have only prednisone. So
that's it.
We don't educate directly. We have less bureaucracy. We may go ahead, and with that, I think.
Yeah.
Dr. Idara, may I add to?
Yes, you are the closing statement, Dr. Suresh.
Oh, sure. Go ahead. Finish.
Go ahead. No, Suresh, go ahead.
No. What I'm saying is I'm the only one here in the panel that is a practicing physician rather than the researcher. I'm really happy to be with the esteemed researchers in this meeting, and thanks for inviting me. And as a physician, as a community physician, I strongly recommend that we should consider using the steroids way early in the disease course, especially in India. If you can start these things, then you can avoid a lot of expense. And I hope everybody in there to get into the starting, even the general internist can easily monitor and treat the patient. So big help.
Do you have any colleagues there that can get this started or share the information there in India? And
yes, we have some colleagues that are already on this call, and I'm communicating with them continuously.
Our goal is, sir, we're going to, this ICM are equal to NIH. We're going to talk to them and then try to, if they put a line on the steroid, that will affect the whole India. That's our goal, sir.
Fantastic. Keep me posted. Keep in touch with this.
No, we'll ask you. Yeah, we'll ask you. Maybe we'll conduct a conference directly with them, and then hopefully.
Yeah, I'll be happy to.
That's 1.3 billion. It's just starting there. So, Dr. Ramesh,
if I have to say a couple of things, is please send a message. By the way, we all are practicing clinicians, sir. I'm an ID practitioner, and Dr. Maduri and Dr. Corey are active ICU practitioners. So we are clinicians as well. We happen to do some research, that's all. If I have to say something, would be please tell patients, message across that if they have exertional shortness of breath, they better come to the hospital early. Please do not wait. And at least get checked out in the hospital so that they can be managed on a more early scale. If you wait, and if you fear and coming late, that's when nobody's going to help them, and things are not going to be the best. So that's the only message I have.
Oh, maybe we'll add that if you have exertional dyspnea, call the doctor, start the prednisone maybe, and then go to the hospital.
If you go to hospital, it may not
Dr.
be started.
Dr. Corey, can you please give a closing presentation? Then Dr. Seema Arora will come. Dr. Corey, sir.
No, I just think it was a really great review of the role of corticosteroids in this illness. I don't think that we all know exactly what doses and duration and timing, but I definitely would defer to Dr. Maduri. I think his point of his careful review of the different glucocorticoid efficacy, methylprednisolone, not only based on the old clinical data, but also on what Dr. Meyer Ramesh talked about, which is Dr. Dragisik's sort of genomal transcription study. Methylprednisolone is the drug. That's the one that I use. That's the one that I've been promoting. And I've actually had very good success with it. I have to tell you, I've had patients who failed dexamethasone, who failed prednisone come to me, and I've had pretty good responses with methylprednisolone. So the thing that I want everyone to take home is listen to Dr. Maduri. His doses and that drug is seemingly the best medication and therapy for a primary lung injury. That's my opinion.
Thank you so much, sir. Seema Arora, can you unmute Dr. Seema Arora? She can do closing. Meanwhile,
wow, 99 plus.
Yeah, thanks, Lokesh. I'm unmuted, I think.
yeah.
I'm Dr. Seema, Board of Trustees of API, and I would like to thank all the excellent speakers for shedding some light on the role of corticosteroids in COVID-19. It's great to learn about the effectiveness in the early use of steroids, and have some hope in the treatment of this mysterious disease. Someone asked in the chat a question about offering CMEs for these lectures. So I would like to tell them, yes, we are starting CMEs from May 27th, and President Dr. Reddy has worked on that. And also we are having CME Tele Summit from June 26th to 28th, where we will be inviting many of these speakers who have been speaking for past 1 month, and many more. So please do attend that. And I would like to thank Lokesh, who has worked very hard on this really informative conference, and also Dr. Bijoy for moderating. Thank you.
Thank you. Dr. Bijoy, do you want to close the meeting, sir?
Yes, it was a pleasure, and it was just exciting times. And my sincere hope is that steroids will claim its rightful place in lung inflammation. Thank you all.
Thank you all. Good night. Thank you so much for especially people coming from India and participating, and hope this is just the start of the light, and we'll keep on pushing and helping. Thank you, sir. Good night.
Good night. Thank you. The best to everybody.
Good night, Dr.
Best.
Sorry, doctor.
Good night.
Oh, if I can have if you do a video of this, can you send me a link?
Yes, we are going to store. Yes, we'll send the link, sir.
Fantastic. The best.
Bye.
Thank you, Dr. Maduri. Thanks, everyone.
Thank you. Hey, Bijoy, the best.
Bye.
Nice office, Bijoy. You make too much money. Look at that. It's your office?
Yes.
Hey, you must be an administrator, huh?
Thanks for your coaching.
Yeah.
Thanks for all the training.